So my name is Jake McSparron. I'm pulmonary and critical care physician here at the University of Michigan. Thank you for joining us. Hopefully some of you have seen our prior webinars. Today we're going to focus on COVID-19 best practices, protocols, and guidelines. And we know there are a lot of variability in practice out there, and we're all trying to be evidence-based as we navigate this. Just to give you a sense of who is on the call, it looks like we have about 20% physicians, 40% nurses, 10% advanced practice providers, some respiratory therapists, pharmacists, infectious disease, and administrators. In terms of the size of the hospitals, it's a good spread. There is about 15% small hospitals, less than 100 beds, 50% 50 medium, between 100 and 500 beds, and about a third large hospitals, more than 500 beds. And about 35% of patients care for critically ill patients with COVID. Okay, we can close that. I'm not going to do formal introductions and go over the objectives in detail, but we'll touch on them, and then we'll have some discussion questions that have come up on prior calls and are very relevant to the topics today. We do hope this is interactive, and the last sessions we have had have really been great conversation from the people on the call. So please feel free to put any questions or comments in the chat. If we are unable to answer them in real time, we will follow up. The webinars will be recorded and posted, and there is CME credit available, and we will show some links for that and some other resources at the end. So once again, thank you very much for attending. We have over 400 people registered, and I think we'll continue to see people join as we go. Thank you to the Blue Cross Blue Shield of Michigan for supporting this work. It's really been an honor to participate, and I think we're doing great things for patients in the state of Michigan. This is a list of our panelists. I'm not going to introduce people individually. Fortunately, we're also joined by Dr. Blamoon at Midland. But you can see we have a number of people, different specialists, nurses, respiratory therapists, and physicians. So thank you, everybody. And we have a nice spread of people from different institutions. You can go to the next slide. So this is why we're all here. And I suspect many of you have been following graphs like this. This is from the University of Washington. The graph has changed over the past weeks. But we are continuing to anticipate a peak. It's been pushed back a little bit further. And I think we're all sort of feeling this in the outpatient world and the inpatient world, and certainly in the intensive care unit. Things are different this time around, but we are still strained as a system and as providers. I think at this point, maybe just to get a sense of what's going on at the different institutions, I'll just go around to the panelists. Dr. Blamoon, can you comment on how things are going at Midland and what your numbers are like currently? I think you're muted, John. Oh, still muted. Why don't we go ahead? Okay. Oh, there you go.
Hear me now? Okay. So in the last couple of weeks, we are kind of leveling off in the range of 50 patients. In the ICU, probably have about 12 patients. The rest are in the med-surg floor in the COVID unit. In terms of the vent, we have probably like 10 patients on the vent out of those. So we are kind of leveling off. We're not seeing an increase. A week back, we had a significant increase, but we are kind of leveling off now.
Great. And Max, how about your group up there at Spectrum? How are your numbers and inpatient ICU level patients doing?
Steve, I don't know if you want to give a more updated data.
Sure.
Yeah.
Sure. Yeah, we're Steve Fitz here. We're kind of in a little weird plateauy place right now that doesn't feel like it's real yet, just based on what testing data looks like. We have seen our testing positivity start to drop in our labs for the first time in a sustained way over the last few days. But we're definitely still very full. We're definitely still about 20% or 25% outside of our regular ICU footprint in terms of numbers. I think we have 228 total inpatients right now, and about 60 of those are in the ICU, and most of those are on the vent, but for a couple. And then we have a lot of other ICU volume, still kind of continuing to try to thread the needle between providing care to the whole community versus the care of the COVID patients. And that's been probably the biggest difference, I think, for us compared to the spring, where we had more empty beds, not sure what was going to happen. But definitely still very high acuity and very busy, and our regional hospitals are still very stretched and full. So just kind of a day-to-day balancing and wondering if we're going to get a post-Thanksgiving surge here any day now.
Great. And Henry Ford, Dr. Tatum, Dr. Hurst.
Dr. Tatum give it. She actually just gave me the most up-to-date stats about minutes ago. So if she wants to, otherwise I can present it too.
Yes, thanks. So it looks like we have about 325 patients throughout our system with COVID right now. It's hard to tell how many are in the ICU versus on the general medical wards, but it's about 20 to 25%. There's quite a bit of regional variability. Certainly in the northern areas is where we see most of our patients being hospitalized, which is, in contradistinction to what we saw in the spring. So like everyone else, we're waiting with bated breath to see what's going to happen now that we're about a week and a half out of Thanksgiving, to see if this ticks up pretty aggressively.
Great. And then how about here at University of Michigan, Dr. Wong, Dr. Heisey?
Well, this morning we had 90 in-house on the adult side, 28 of whom were in critical care, none in peds, 3 in children and women's, 1 of whom's ICU. So our numbers have gone up certainly over the last 2 weeks, but I'd have to say over the last week, we are hovering at about the same level. As again, waiting to see in the post-Thanksgiving timeframe what lies ahead. I'd like to hope that maybe we're past that blip, but hard to say.
Great.
Yeah, and our symptomatic testing positivity rate's around 18%, which is higher than it's been.
Yeah. Okay, thank you. And then if anybody on the call wants to type into the chat, let us know how their system is doing. There's a comment here from Sparrow, and we'd be thrilled if you want to join the conversation. We'll definitely reach out. If other systems are interested in being on this panel, please let us know. We really want this to be an open conversation. It's been really helpful so far. Okay, why don't we go to the next slide? These are the objectives we already covered. You can go ahead and go to the next slide. So we'll start with a question for the Henry Ford system. And we did touch on this on the last webinar, but as things have evolved, the current approach to endotracheal intubation for COVID patients, but then also for non-COVID patients, or for patients we assume are non-COVID. I think we've all had some surprise results after patients are intubated with unexpected positive results. So Dr. Tatum and Dr. Hurst.
Hi, thank you for the question. I think there's a little bit of variability within our health systems, just depending on the size of the hospital and the capabilities. Here at Henry Ford at the Detroit campus, we have the advantage of having anesthesia help us and be our primary intubators. I think there are a couple of important things to keep in mind, particularly for COVID patients. I think we all focus on the fact that we want the most experienced operator at the bedside to do the intubation. And we want to do everything that we can to ensure a first pass success. So Our anesthesiologists and anybody who is at the bedside, is wearing an N95 and or a PAPR. Most of our anesthesiologists will actually wear a PAPR. We minimize the amount of people in the room, but we always have an additional provider to manage the hemodynamics, which we know will be a potential problem at the time of the airway, so that our anesthesiologists can really just focus on securing the airway. We also make sure that we have viral filters in line for our valve masks, so that again, we minimize the chances of aerosolizing live virus within the room. That's really important. We pre-oxygenate just like everyone else does, to make sure that our anesthesiologists have some leeway for when they actually do RSI, because the patient will, not be able to spontaneously breathe for, 15 to 30 seconds while the airway is being secured. So we spend appropriate time pre-oxygenating our patients as best we can. So it really focuses on making sure we have experienced operators, rapid sequence intubation, viral filters in line for the bag as well as for the ventilator circuit, and minimizing extra people within the room. We also make sure we use sort of a buddy system to ensure that we don't accidentally self-contaminate ourselves as we're in the room. And so we keep an eye on each other as we're doffing our PPE in the room. And then again, as we doff our eye shields outside of the room. So that's pretty much the procedure we follow. When we're thinking about non-COVID patients, our practice has been sort of mutable. Initially, we would just assume everyone was COVID positive and do the same procedure, particularly with PPE. Now that we have sort of a counter distinction between the two, the process is pretty much the same for the provider. We don't necessarily call anesthesia, but we follow the same process in terms of securing the airway for our non-COVID patients.
So if that's for the main system and for some of our community and larger systems, when we speak to other systems that I know are listening on the call, there are a couple of ways to extrapolate to what Geneva just relayed with what we're doing with everybody. One is, as she mentioned, talking about treating everybody as if they're positive, potentially positive. And in some of the smaller, like critical access and community-sized hospitals, with the rate of transmission that they're having across the state, it's probably safe just to assume that everybody is positive and wear your PAPRs and protect yourselves at all times when you're in the rooms for safety's sake. Because even if you have tests, they're not always, sometimes you have false positives, false negatives, and to decrease rate of transmission with as high as it is, they would recommend that. And not everybody we know also has anesthesia teams. And so standardizing your team, if you can possibly get either a CRNA or your emergency department room or an intensivist or even a hospitalist that is standardized to your team and it's the same person, it helps because there are some differences with your COVID patients. Although an intubation can be an intubation, airways you have to take really seriously. And so we would always recommend having a backup plan when you go to intubating your patient. We've had enough, and I guess to tell some of my background, I do telemedicine too, and telemedicine is oftentimes not in tertiary care centers, it's in community and in smaller sites, so that they don't have very many resources. And so what I've been recommending to them is to make sure you always have a backup plan, meaning a secondary way to intubate your patient. So if you go in with a glidoscope, make sure there's a bronchoscope also available. If you go in with direct visualization, make sure you've got video visualization. And if you don't have that type of support, that's putting you at risk, but also have maybe a backup provider who does not have to come in the room and expose themselves potentially to COVID, but can be outside to either give guidance or come in and jump in if the first provider doing the intubation is not able to do so. Another key thing we've noticed is, depending on the skill level of the RT and some of the people intubating, pre-oxygenation is key. If you have the ability to pre-oxygenate, that's great. But if you have somebody who's only satting in the 90s, who's been on BiPAP, and they already look like an ARDS type picture, sometimes when you take the BiPAP off and try and bag them, you're not creating as much PEEP as you were even getting on the BiPAP. And so they're recommending go straight from the BiPAP to intubation and tolerating a little desaturation, because you have less than a minute that they're going to be able to maintain their saturations greater than 90. But if you can pre-oxygenate, by all means do that. Patients are de-recruiting very quickly because they're looking typically like ARDS patients when they're COVID. If you can wear a PAPR, they're recommending that as the best and safest way. But if you don't have PAPRs available, an N95 plus a face shield, so covering your eyes and the mucosal spaces anytime you go in. And really, you know, I had a scary situation the other day. I had a woman who we had just, we had intubated, extubated, and she'd been doing well for about 24 hours, but then she acutely decompensated. And I was ready to run back in the room and do everything, but everybody was like yelling at me to put my PPE on. So even though she dropped in her SATs, it was better and safer for my team to put the PPE on before we walked into the room to re-intubate the patient. So I would just say that don't be a hero. Don't try and go in and expose yourself, because in some of these smaller communities, you are the provider treating these patients. If you also get sick, that just creates more issue. The other biggest recommendation is with anything with airway is if you go in all agitated and distressed because you've got the PPA on or because they're desaturating or whatever the circumstance, if you can be calm as a leader walking into the room, that's the best approach to ever have. If the person who's primary doing the intubation or leading the code or whatever's going on can be calm, the rest of the team can be calm. We've also avoided some intubations because if their work of breathing is less than 30, even though their SATs might not be 90, sometimes we are finding that healthier and younger patients can actually tolerate in the high 80s on high flow nasal cannula or BiPAP without having to be intubated. So if their work of breathing is okay, then sometimes we're holding off on that, just as another key point to think of. And then just general things with patients, making sure if they're morbidly obese that you're ramping them, which gives you the key of getting their earlobe at the same level of their sternal notch for optimizing the ability to see the airway. And then trying to avoid succinylcholine because once you paralyze them, if you're having any difficult time oxygenating them, you can't get the airway and you can lose them. And we've had, unfortunately, several codes of young people who should have been able to be intubated because they were so de-recruited and so ill because of certain things that happened at the bedside. So those are just all the keys that I've learned in helping smaller sites without the resources be able to intubate their patients.
Thank you. That's helpful. There's a question in the chat. I think today we will have time to sort of do question and answer as we go. And Dr. Heisey said he could answer it, but the question is about the timing of intubation. Are there levels of high flow nasal cannula or non-invasive ventilation that sort of once you get there, you would advise intubation? Are we waiting too long? And this has certainly changed over the past few months. So Dr. Heisey.
Yeah, thanks, Jake. So that's right. So you know that the evolution of this whole COVID treatment has been so quick. You may remember at the beginning was, well, they hit 6 liters nasal cannula, just tube them because they're doomed. And that's just not true. And what we've learned is with heated high flow in the spring surge, it was a 50% intubation rate, which is not bad, but now we're down to probably 25%. We have opened a moderate care unit for heated high flow. I know that some of our hospitals are on this call, on this webinar, and they have been using this ROX index, which is not perfect, but you can look at it at MedCalc. It's pretty much a PDEF or SF ratio combined with respiratory rate. And what that lets you do, at least in part, is feel somewhat more reassured, if you will, if someone's at a higher level of heated high flow, higher FiO2, yet they're, as you say, not labored or not too tachypneic, that in fact the ROX index is more than 5 and they'll probably hold. And we have seen that to be the case. I'm not a big BiPAP user, generally speaking, for hypoxemic respiratory failure based on the Florelli trial of a few years ago, and the notion that perhaps that might generate large tidal volumes in people who otherwise, if they had non-invasive or invasive ventilation, would be called ARDS. But oxygenation would be the key. But you can't apply a ROX except for heated high flow. That was the one paper in the Blue Journal that was validated. So I was asked the other day about what about someone on 15 liters of nasal cannula? And I said, well, it's just not the case. And I showed them some information comparing 60% face mask to 60% heated high flow at 50 liters with just worker breathing and PDEF ratio, all these things being better on it. So we're using a lot of heated high flow, and in non-ICU settings, we're using the ROX as a guide, not as a absolute, but as a guide to safety, and that permitting higher FiO2s with heated high flow under circumstances we might otherwise feel more concerned.
Great. I think we'll keep, this is a relevant topic, so I'm going to keep this conversation going for a few more minutes. I know we have Alex Gill and Andy Wyruck, critical care nurse and respiratory therapist. Anything from your standpoint that's different about this, or that you've learned along the way, that you think would be important to share with the group?
I think it's important to note that what Emily said, having a standby provider outside of the room, it limits your exposures. I think that's very important. I think typically what I've seen in our ICU is there's times when we maybe don't have our anesthesia providers doing the intubation, and we have our actual CCMU fellows. There's a 2-provider rule, and we always have someone outside. So it's always good to have the backup and using the glide scope to ensure you're visualizing the chords properly. Other than that, everything that the Henry Ford colleagues have said seems to be appropriate and seems to also be what we do here. So from my standpoint, it sounds accurate.
One of the things we did early on with our ED colleagues was, because the PPE that's needed, we're not used to intubating with that on, and the noise level, if you are wearing a PAPR, just being able to hear and communicate better. And so one of the things we did was we actually practiced some intubations in PPE before, obviously while the surgery was going on, but just do some dry runs, so to speak, on some mannequins, just so you can build that team communication. Having someone outside to help coordinate helps as well, just so they can see and anticipate and maybe hand something in that you weren't expected that you needed. But again, I think going in with the mindset of being prepared and being calm is always helpful.
Great, and I will have some sample algorithms and protocols that we will post that will be available on websites, and you can see things have not been updated extremely recently, and things have changed. This one was suggesting avoiding high flow nasal cannula, which we know we are not doing. It's from our group and from Penn, and then another from the emergency room. But please feel free to share protocols, email us, or post things as you're able to do, so we can all learn about this together. And then Dr. Fitch, just quickly, you had a comment also to add to this one?
Yeah, I was 2 things that, because I echo all that's been said completely. We are also kind of making sure that we are have 2 clamps available when we have to disconnect. I think that's important from a viral spread perspective as well, and that's one other addition I would throw in there. Completely echo, no emergencies in a pandemic. Get your PPE on always, no matter what's happened, what's bleeding, who's on the floor. You got to do that to protect yourself. And I would agree with the BiPAP piece. We went through a section here not too long ago where several of us from a pulmonary consult perspective were kind of wandering into these rooms, being asked to see somebody. They're on BiPAP, they're breathing, 1,200, 1,300, 1,400 mLs per breath, and you're kind of going, this is probably not optimal for, people with lung injury and things. And so we really kind of doubled back with our hospitals teams and really have tried to, put the, limit on that as much as possible, heated high flow, instead, and that seems to be working better.
Okay, great. Let's move on to the next question. Next slide, please. And this will be, we'll start with the Spectrum group, but get input from all of the panelists. What about the current approach to tracheostomy? And there was already a question in the chat about this. Is there a protocol and algorithm, and how has this changed, and what are the thoughts now?
Thank you, guys. I'm the Director of Interventional Pulmonology. Can you hear me okay?
It's a little glitchy, but I think so.
All right, how about now? Can you hear me a little clearer?
Yes.
Excellent. So, we need to understand that uncontrolled variation is the enemy of quality. So you cannot make a blanket statement and present with a protocol and draw a line in the sand and say 10 days or 14 days or 21 days. At Spectrum Health, we provide personalized care. We analyze each case individually, and we try to figure out best timing based on multiple factors. Some of the factors that affect more a delayed tracheostomy is multi-organ failures, prone positioning, essentially factors that are likely not going to contribute. The tracheostomy is not going to contribute to the overall outcome. And there are some situations in which we like to push for an earlier tracheostomy before 14 days, even before 10 days. And that would be if there's any type of trauma in the airway, if you need to enhance pulmonary hygiene, maybe if you're starting to see that there's a lot of cumulative effects of sedation, or at some situations you need to consider ICU capacity. You cannot have a patient, we cannot have an ICU at capacity, and there's some patients that we may need to do a little earlier because we know that they will need more than 3-4 weeks of mechanical ventilation, and we need to get them liberated from the endotracheal tube. So taking into consideration that there's some factors that will push towards earlier or late, then also we need to make sure that we know that if we do tracheostomies, if we perform tracheostomies before the 14-day mark, there's no benefit mortality-wise, but there's benefit from liberation of mechanical ventilation by 6 days. And there's benefit also by ICU length of stays roughly by 6 days with an earlier tracheostomy. Again, the holy grail is mortality. We cannot modify mortality based on that. And also a situation that we consider when we time is the ability of the patient to tolerate tracheostomy. And it's very simple. We do an apnea test. We put the patient on apnea for maybe 5-10 seconds, which is the duration of time that we can have to shut down the circuit for us to open the system, either to put the bronchoscope or to get the wire out and put the tracheostomy itself. So we haven't seen differences between percutaneous and open. We haven't seen a single physician, to my knowledge, that has contracted COVID-19 stemming from tracheostomy. And we observe strict PPE with N95s. We don't like to use poppers much for trach because we cannot communicate. But overall, I'm pleased to say that we have triple our volumes in tracheostomies with no mortality and no healthcare workers being infected. I don't know if that was comprehensive enough.
Yeah, that was very helpful. I'm going to, Dr. Blamoon, I think you don't have the same number of pulmonologists out there, and I do not believe an interventional pulmonologist. Can you speak about your experience at Midland with tracheostomy and who's doing them and how you've been doing this?
So we evolved, Jake, as you know, with the tracheostomy. So early on in the course of the disease, in the first wave, we actually were holding off the tracheostomy for a long time on these people, and people waited sometimes even for 28 days to get their tracheostomy. But now we are leaning toward the tracheostomy about 2 weeks out. And we have also the limitation with that we don't have an interventional pulmonologist, so we rely heavily on our surgeons. General surgery been great to us, and they do the tracheostomy for our population. The problem with the tracheostomy is, like was alluded earlier, is that we cannot prone these people. So if we believe that there is still an active disease and we still need to prone them because they are still on a high PEEP, we hold off on the tracheostomy for a longer time. So we have people that we did tracheostomy at 14 days. We have people did tracheostomy at 21 days, and so on and so forth. So really every case is different where they at in the course of the disease. And again, like alluded earlier about if they have multi-organ failure. So these are all factors that comes into play when we make the decision for tracheostomy.
Great, thank you. About the Henry Ford group, anything different? I know you have an active and large interventional pulmonary program. Has the experience there been different at all, or are there anything else you've learned along the way?
No, I think our experience has been very similar to what everybody else on the panel has mentioned thus far. I think our only thing that may be a little bit different is that we require sort of multiple physicians to evaluate the patient. So we require 2 attendings, two intensivists to actually say that the patient needs tracheostomy, which is a little bit different. But otherwise than that, the process is the same.
And anybody from the Michigan group want to comment? I know I've personally been involved in a number of tracheostomies at the bedside, and we've worked with our surgeons as well for higher risk people who need the OR. But Dr. Heisey, Dr. Wong, anybody want to comment on that?
Well, Bonnie, you just posted that paper. Why don't you say what that's about?
So I agree with what most people have said. You know, we will consider tracheostomy once active issues like proning are resolved. Personally, I've been asking our interventional pulmonologists or our ENT colleagues to consider tracheostomies in patients where it's been really hard to get them down on their sedation. They're usually on multiple agents. They may have underlying mood or psychological disorders that make it really hard for us to wean their sedation, but to keep them synchronous with event. So that's when I've approached them earlier than even day 7, perhaps. I'm not sure if anyone could see, I think Bob could see the paper posted, but one of our fellows actually just published a paper showing that there were decreased sedation requirements once tracheostomies were placed, better RAS scores, better mental status, and more SBTs being able to perform.
For me, the issue, Jake, is that the bad ones, have a long course. And even though I've got interventional pulmonology support that is phenomenal, I worry, we just discussed this on rounds, I got a guy who's kind of due, but he's still on 16 at PEEP. And I kind of worry about de-recruitment under such circumstances. That's a little higher PEEP than I really personally am happy with to pursue tracheostomy. I don't know what our colleagues at other institutions feel. The upper limit of PEEP they feel is trach worthy.
I have 2 comments of that. The number that comes to mind is really what's the BMI, right? So, and how stiff the patient is. But as interventional pulmonologists, any PEEP more than 10, I always worry about the recruitment and then having some hypoxemic events that may translate into some adverse events. But there's no right or wrong answer with regard to the PEEP. If the patient needs a trach, then we have to evaluate risks and benefits and move forward. But also, I want to bring up the attention to all of you that we expect a 5 to 10% likelihood of complications, tracheal stenosis, and long-term sequelae from tracheostomies and intubations. So I want everybody to understand that even though we may engage in tracheostomies earlier and try to liberate from the vent, we also are going to create a massive amount of work for interventional pulmonology and ENT for resections. The numerator is going exponentially high, and that will be a second wave of problems, surgical problems that I don't know if we as a system or in the country have the capacity to absorb.
Well, thank you for that reality check. For me, 12 is the new 10, but 16 is still out.
There's a somewhat related question that has come in on the chat, and I know we have Dr. Lampin, other infectious disease and infection prevention experts, about chest PT, percussion therapy, as well as tracheostomy. Is there anything that is out there regarding, we're waiting to sort of, early on we were trying to clear people before we would trach them. So we would wait for, 1 or 2 negative tests. We've moved away from that, understanding that appropriate PPE is safe. But Dr. Lampin, do you want to comment on that? And then also maybe Alex Gill from a nursing perspective.
Yeah, sure. I mean, it's funny from the infection prevention side of things. I lay awake at night looking at this ever increasing list of what is being tagged on as aerosol generating procedures. And I've tried to use some semantics in our own institution to call them higher risk procedures so that they don't get tagged as AGPs. So it's been fascinating over our career. We've been, fighting with people to wear masks, and now everybody's clamoring for N95. So it's this kind of reverse flow of things. But I think more and more as we get evidence related to transmission of COVID, the further out patients go, the less contagious they are. And I mean, I think it's an interesting phenomenon, at day 10 and certainly by day 20, the risk of any of these individuals being contagious, I think is really diminished. The CDC, it's interesting, they have a number of internal publications, so it's not fully peer-reviewed data that you can get your hands on, where they showed that after day 14, none of the patients, even if they were in the ICU or immune compromised, were capable of producing, replication or transmissible competent virus, right? Now, interestingly, the CDC kind of tagged on fever as also a surrogate marker, despite the fact that none of the viral shedding studies ever looked at fever as the aside of that. But I think kind of time has told us that when we're performing some of these upper airway procedures, which clearly are in an area where there would be risk for COVID transmission, the further out you do it, the safer it is. And probably after day 10, your risk of transmission and acquisition is really quite low.
Great. And then Alex, can you comment in terms of the use of chest PT and sort of standard therapy that we do for respiratory failure patients and patients on high oxygen?
Yeah, so I think for a lot of percussion practices here, a lot of it's for secretion clearance and clearing up any kind of fluid buildup or anything inside the lungs. So I think it's really patient specific, to be honest, dependent on the amount of secretions. From my experience and our experience here, we don't typically have PMPD orders placed. It's more of like driven by nursing based on their assessments and stuff like that, unless the physician truly wants something specific. So the caveat with the PMPD though is it requires a lot of positioning of your patients. So you run the risk of popping the vent off, which increases risks of exposure and AGPs. So I would always caution nursing to be very cautious with their tube, monitoring their tube placement and such to avoid disconnecting from the vent. I would say that it's appropriate, but it's also very patient dependent.
Got it. Okay, thank you all very much. There's some great conversations going on in the Q&A also, so please feel free to keep
hey,
those
Jake.
conversations. Yes.
One thing about the tracheostomies, I think it's from a nursing standpoint, very important for communication, planning, and preparation. One thing that we've done in our unit specifically is our interventional pulmonologist has a specific set of supplies that he likes. So we've created him his own bedside cart that, so he informs leadership of when he's tracheing, and then we get all the supplies prepped in the cart, and then we pull it to bedside for him. So the preparation is always key, and always strong communication for nursing, I think, is a huge benefit. So.
Great. Gus, did you want to comment anything on that? How are you doing that? Do you have a cart, or you bring your own equipment? Is there anything special from a nursing and sort of support standpoint?
Right. We have been seeing a little bit of, supplies issues with some sizes not available, some national shortages, if you will. So we have enough supplies to get through the cases. We do not have a cart committed. We have various ICUs in various floors. So intuitively, it's very difficult to have 7 different carts for all of the ICUs we service at these 2 different hospitals. So, but I can tell you that the system has been excellent at communicating. We tell the nurse, we tell the respiratory therapist, the respiratory therapists know exactly what they're looking for. So I would say that within 5 to 10 minutes, with good communication virtually or otherwise, we have all the supplies we need. It's a seductive idea to have a tracheostomy cart, and definitely we'll explore it, but we haven't had any hiccups regarding this. We never had to trach somebody we didn't have what we needed. Usually, and now we're changing vendors. We're moving towards a more comprehensive vendor that in one tray, they have the tracheostomy and all the insertions. So it would be a one-stop shop.
Great. I think we're doing okay on time. I'm going to put up another question that came up in the chat, probably for you, Dr. Lampin. There's a comment about infection control, transferring a stable patient out of the ICU if they have a new fever. That makes me a little anxious given our recent bed crunch and capacity situation. If I were not allowed to send a febrile patient out of the ICU, I think we'd be in.
Right. It's funny. I was about halfway through typing the answer to that. So, I mean, it's so difficult, obviously, to assess remotely, but I've really tried to not use fever as this kind of go, no go criteria. We've seen a number of patients that clinically continue to improve, and you watch them, their oxygenation status is improving. Maybe they've been extubated. And overall, you see these patients getting better. And then day 7 to 10, they start spiking temps again, right? And I also catch these on the antibiotic stewardship side of things. When antibiotics get started, as people start to do this workup for secondary bacterial infections, and we come up empty-handed. So, I mean, this certainly appears to be, whether it's fever related to ARDS or to some type of, vasculitic component associated with COVID, But there certainly appears to be kind of this prolonged inflammatory response. And I try not to get overly anxious if fever is our only marker of ongoing infection or lack of resolution. And so, you know, we don't use fever as a criteria to put people in our ICU. We would certainly transfer them out if they were febrile. We've had some patients that we've discontinued COVID isolation if we feel that we can attribute their fever, you know, to other causes. And so we've done that as well.
That's helpful, and Dr. Pawa, who's putting these questions, is really helpful to have the input and comments from different institutions. So please.
I think one other thing to mention there too is that has been on our minds a lot clinically, is a lot of these tend to pop up in my anecdotal experience, you know, someday after that 10-day period when you stop the Decadron, and certainly the number of people that we've run across, you know, where there's a question about a ventilator associated pneumonia because their x-rays gotten a little bit worse and they've got a little bit of fever now at day 12 or day 13 or 14, and whether this is, you know, truly infection, or as Russ says, it's a residual of the COVID or process, or if it's, you know, some other inflammatory thing that you've kind of stopped covering up with steroids. That comes up a lot.
Great. Okay, let's. This is another sample again of evolving policies, and I really do encourage people to share the protocols they have, as I'm sure we could all learn from each other. And we've learned a lot along the way from our tracheostomy. We used to wait, you know, 3 weeks. It was a bit of a long process, and we've gotten, I think, much more nimble with this, as it sounds like many of you have as well. Let's go to the next slide. And this one will start with the Michigan Medicine Group. And I know this is a moving target and people have strong opinions on both sides of this, even before COVID. And there has been some information coming out from ELSO about the COVID outcomes for patients on ECMO. But just to comment on the selection of appropriate patients for ECMO.
Yeah, I can start. So I think this is also an evolving topic where early data showed that mortality rates were actually quite high with COVID ARDS patients on ECMO, but that was during a time when mortality rates were higher in general. And I think, Jake, what you're probably referring to is the data from the ELSO registry more recently showed mortality rates closer to 40%. So more similar to the non-COVID ARDS population. In general, you know, we are considering ECMO support as rescue therapy. So this is in patients with refractory hypoxemia on maximum ventilator support. You know, usually we've tried paralysis, we've tried proning, or we can't prone because there's hemodynamic instability or worsening oxygenation or ventilation. We've tried pulmonary vasodilators like nitric oxide before we're calling for ECMO evaluations. We are often limited by a number of contraindications in many of our patients. And for our population, that tends to be multi-system organ failure. That tends to be chronic illnesses like cirrhosis or end-stage heart failure or lung disease, and any sort of major bleeding issue or cardiac arrest. And then we do have limitations in our ECMO circuits as well. Number of ECMO circuits, I should say.
Great. Bob, did you want to comment on this at all?
Yeah, and my comment would be, you know, you can do a lot with a little, as it turns out. By that I mean, and I've tracked this for some years, you know, among patients that are actually referred here for ECMO evaluations, clearly under a third or even closer to a quarter actually get cannulated. And I think it's important to recognize that the things that we're doing are not proprietary, you know, proning and paralysis and so forth. So, so that you can still do a lot with them. And in fact, the earlier trial that was done in the UK that's seemed to support ECMO called CSER was felt to be more a trial of regionalization, which is to say the people that got sent down to Leicester versus the ones that were randomized to being left behind had a lower mortality, but that was accounted for by non-ECMO care. And so there is a lot to treating an ARDS patient, proning, and these are not nothing. They're important and complicated interventions in people who are sick, but a lot can be done.
Great. The Henry Ford Group, Dr. Tatum, Dr. Hurst, do you want to comment? I don't know. I think early on, I know with the numbers in the first surge, I'm not sure if you all were doing ECMO and sort of currently, I believe there are some patients on ECMO, but could you comment on your experience?
Yes, thanks for that, Jake. So yes, in the initial surge, we actually were not considering ECMO, clearly because we just didn't have the capability with just the enormous surge that we had. This time around, similar to the other systems, we are considering patients and evaluate every patient individually, much like what was mentioned earlier, that, you know, we are challenged by the fact that the majority of our patients who are being referred to us for consideration for ECMO either have not had all of the advanced ventilator management strategies available to them done, or they have multiple comorbidities or chronic illnesses that may preclude them from being an acceptable ECMO candidate. So much like the experience that Dr. Heisey mentioned with, you know, about a third of patients being referred actually being cannulated, that's pretty similar to what we're experiencing here, which isn't necessarily a bad thing, right? I think it does emphasize the importance of doing the ventilator management that we know has a strong evidence base that has been proven to be beneficial for the treatment of our patients with ARDS, whether COVID related or not. And so I think that's very important. There's always this tension of trying to get these patients, you know, referred specifically for ECMO, but I think it has to be some understanding that ECMO may not necessarily be a guarantee. I think, just as was mentioned in the CESAR trial, being at an institution where advanced ventilator management can be done is incredibly important.
And how about the Spectrum group? I know there have been some ECMO cases up there. If you want to comment on your process and how it's going there.
Sure. Yeah, I mean, I would echo everything that's been said. I mean, I think, you know, I like having the availability of ECMO as another tool, but I agree with Dr. Heisey that the things that we have known to be helpful are the most important things, and we should make sure that we're deploying those as completely as we can, because it's a very resource intensive therapy in the middle of a resource constrained situation when you're in the middle of a pandemic surge. So, and that's exactly what we ran into. A couple of points I guess I would make is that, you know, we didn't have the same level of surge on this side of the state in the early spring, but you know, maybe arguably had a little bit more of an impact here lately, and so we did put some people on over the course of the late spring and the summer, you know, we have not been enamored with the outcome so far. In fact, our outcomes in VV ECMO for COVID are considerably worse than our generally very good outcomes in VV ECMO for other ARDS, and so I think it has caused us to reconsider that a little bit. You know, certainly the broader notion of when you look at the number of patients that we have coming into our hospitals and not coming to the ICU, you know, since you know, maybe since the recovery trial was published and we've been using the steroids more consistently and uniformly, you know, it does raise a question as we look at some of these folks that don't get put on ECMO but sit in our ICU with really bad compliance and difficult to ventilate and don't seemingly make any progress. Are those treatment failures of some sort that were kind of pre-selected to not do well? And, you know, putting them on ECMO isn't going to make that better. And so I think we've really tried to be much more selective this time around in that context, but then also just because our resources were constrained. And when we started to look at broad, even, you know, relatively reasonable criteria that are typically talked about, and if you look at, what's typically put forth by also and others. That seems in line, but it really does. You could support a lot of people that way if those were your criteria and you put everybody on. So we had to find ways to be more selective about that. We have ratcheted those criteria down quite substantially, and you really have to be able to make a good case that there are compelling reasons in our historical criteria that would fit with survivability and likelihood of survival. And we really are not putting anybody with any comorbidities, anybody with advanced age, and really looking at weight and some of those things really carefully, because those are the things that tend to portend worst outcome. The other thing just relatedly is just that as we looked at our bed capacity and our ECMO capacity and the fact that we had nursing care ratios that were not typical and are not normal, you were starting to ask the questions, do we have to cancel certain surgeries and cancel other things where we know that we can provide benefit to a level 2 cardiac surgery patient, who's going to be in the ICU for a few days, but is going to get better and go home. So there are some kind of, distributive justice decisions that have to be made in some of these instances, and they are difficult, but they're important because we have a community of people, as we mentioned before, that we have to care for that is more than just COVID patients.
Yeah, thank you for making that point. I think especially during this second big surge, we're all feeling that and trying to balance that as we're not shutting down all of the operations like happened the first time around. This is definitely different. This is the ELSO guidelines. They did put out a COVID specific document, and this, as you heard, it doesn't mean that we're cannulating every patient meeting these criteria. It's always a multidisciplinary conversation and a real thoughtful approach. And the people who have gone on ECMO, these have not been short runs for most of them.
The other thing I will add, and you're right, they're not short runs. But when we looked at our cohort, what we found was that they were all cannulated pretty early in their course. Most less than 5 days of their hospital stay, not even intubation, and a wide range of ages. So there weren't things that you would normally think of as portending poor outcome as driving the poor outcomes. And so, I do think we don't know enough. But we do know that standard ARDS management is helpful for most of these patients, and that's what we should really, be first and foremost with.
Yeah, and we've had a lot of issues with the BMI cutoffs and conversations around that, given there's been a fair number of young obese patients who would otherwise be good candidates. Thank you all for the input, and feel free to keep things going in the chat. Why don't we go to the next slide in the interest of time? People can feel free to keep posting questions. And next slide one more time. So this is related to the CME. If you're interested in obtaining CME, you can follow these instructions. And again, this will be recorded and archived and available as well. Next slide. This is something we wanted to put out there. It's the COVID-19 Colleague Connect line, and really this is being supported by Blue Cross Blue Shield. It's a team including an intensivist, a critical care nurse, a pharmacist, and a respiratory therapist who are available 24/7 to answer questions related to managing these patients, especially for people at institutions where they have not had the sort of high volume or experience that other places have. It's currently in a pilot phase out of Michigan Medicine, and soon will be expanding, and something will be staffed by volunteers from the other large institutions throughout the state who have had a ton of experience. And this is sort of part of this ongoing conversation, but really just trying to help the entire state and take the best care of these patients that we can. So please feel free to share this phone number and look out for updates about how this will evolve over the next few weeks and months, depending on how things go. Next slide. I do want to give a special thank you to HMS, who's really the brains behind this operation and been supporting this. There have been a few comments and questions about making the protocols and slides available. The HMS website we'll link you to another website here, the MCCN, Michigan Critical Care Collaborative Network. Essentially, things are going to continue to be updated. Resources will be shared from throughout the state and also from national and international organizations as care evolves and protocols evolve. But please keep an eye out as things change, and please share your own protocols that you've developed and your experiences that are working. Next slide. We are going to keep these webinars going. The response has been very positive. We've all learned a lot here, and hopefully these have been valuable to those of you on the call. The schedule is changing a little bit, so the next session on the 16th is going to focus mainly on the hospital at home, and there have been a lot of efforts to really try to shift things to the outpatient setting and how do we support these patients outside of the hospital. So we'll have some content experts talking about that. We'll touch on COVID-19 therapeutics, although that will be another topic for the future, both inpatient and outpatient. This is really shifting. I know there was just a question posted about ivermectin, prostacyclins. There's been a lot of things, and it's changing every week. So please stay tuned and share this around. Again, they will be recorded. Next slide. You can go ahead and visit the Mi-COVID19 HMS website, and again, share your resources. There's an email address here, mycovid19@umich.edu. We will reach out to those of you who commented that your institutions would be interested in participating on this panel. That would be great, and we'll get you on the panel. And if you are not interested in being on the panel, but you have resources to share, please send them in so we can post them. And I think, is there any more slides there? I think that's it. Great. So thank you all for joining us. And it's really been a privilege to be part of these conversations. I think this has been an exciting time, and we're learning a lot from everybody throughout the state. So thank you for your participation. Thanks to all the panelists. Have a good day and take care.
Thank you so much. Thank you.
Thanks so much.
Thank you, everyone.